Good morning. We are going to discuss anesthesia for the elderly patient and the principles of geriatric anesthesia. To begin, why is this an increasingly important area of practice?
Good morning. It is important because of demographics and surgical demand. The population is aging across the developed and much of the developing world, and older people undergo a disproportionate share of surgery. A large and growing proportion of operations are performed on patients over 65, and the fastest growing surgical group is those over 85. These patients have reduced physiological reserve, multiple comorbidities, polypharmacy and frailty, and they are at higher risk of mortality, cardiovascular and respiratory complications, delirium, functional decline, and loss of independence. The anesthetist's role extends beyond the operating theatre into shared decision-making, optimization, and the protection of brain function and independence, which is why dedicated guidance now exists, such as the Association of Anesthetists and Centre for Perioperative Care Standards, and the Perioperative Medicine for Older People Undergoing Surgery, POPS model.
Distinguish between chronological and biological age.
This distinction is fundamental to good geriatric anesthesia. Chronological age is simply the number of years lived. Biological age reflects the actual physiological reserve and function of the individual, which varies enormously between people of the same chronological age. A fit, active 80-year-old may have greater reserve than a frail, comorbid 70-year-old. The clinical implication is that decisions should be based on biological age, frailty, and functional status, not on a number. Denying or modifying treatment on chronological age alone is both clinically wrong and, in many jurisdictions, discriminatory.
What is frailty and why does it matter?
Frailty is a state of increased vulnerability to stressors, resulting from a cumulative decline across multiple physiological systems, with a reduced ability to recover from an insult such as surgery. It is distinct from age, comorbidity, and disability, although they overlap. It matters because it is one of the strongest independent predictors of adverse perioperative outcome, postoperative complications, delirium, prolonged stay, loss of independence, institutionalization, and death, often a better predictor than chronological age or individual organ disease. It can be measured. The clinical frailty scale, a 9-point scale from very fit to terminally ill, is widely used at the bedside. The Fried phenotype, based on weight loss, exhaustion, weakness, slow gait, and low activity, and the Edmonton Frail scale are also used. Identifying frailty allows targeted optimization and realistic, honest shared decision-making.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard. Take me through the physiological changes of aging, system by system. Start with cardiovascular.
I will take each system in turn, with the anesthetic relevance. Cardiovascular. Arterial stiffening and reduced arterial compliance cause systolic hypertension and increased afterload, with left ventricular hypertrophy and diastolic dysfunction. The myocardium and conducting system fibrose, reducing the maximal heart rate and the response to beta-adrenergic stimulation. So the aging heart is preload-dependent and tolerates tachycardia, hypovolemia, and fluid shifts poorly. Baroreceptor reflexes are blunted, predisposing to postural and anesthetic-induced hypotension.
Respiratory.
Respiratory. The chest wall stiffens while the lung loses elastic recoil. Closing capacity rises and encroaches on tidal breathing, causing increased ventilation-perfusion mismatch and a lower resting arterial oxygen tension. Protective airway reflexes are blunted, increasing aspiration risk. The response to hypoxia and hypercapnia is attenuated, and respiratory muscle strength declines. The result is a reduced respiratory reserve, greater susceptibility to postoperative pulmonary complications, and increased sensitivity to the respiratory depressant effects of anesthetic agents and opioids.
Renal and hepatic.
Renal. There is a progressive loss of nephrons and renal mass, with a declining glomerular filtration rate, although serum creatinine may remain deceptively normal because of reduced muscle mass, so the estimated GFR overstates renal function. Concentrating ability, sodium handling, and the response to volume changes are all impaired, predisposing to dehydration, fluid overload, electrolyte disturbance, and reduced clearance of renally excreted drugs. Hepatic, liver mass and blood flow decline, reducing the metabolism and clearance of hepatically eliminated drugs, and reducing plasma protein synthesis, which affects drug binding.
And the central nervous system.
Central nervous system. There is a reduction in brain volume, neuronal density, and neurotransmitter activity, with reduced cerebral reserve. Anesthetic requirements fall. The minimum alveolar concentration decreases by around 6% per decade beyond 40, and sensitivity to all central depressants, particularly benzodiazepines and opioids, increases. Autonomic and thermoregulatory function decline, so the elderly are prone to hypothermia. Most importantly for outcome, the reduced cerebral reserve underlies the vulnerability to postoperative delirium and cognitive dysfunction, which I expect we will discuss. Alongside these, musculoskeletal changes, sarcopenia, osteoporosis, arthritis, and skin fragility affect positioning, regional technique, and pressure area care.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
How does aging alter pharmacokinetics and pharmacodynamics?
Both change, and the combined effect is that the elderly need less drug and are more sensitive to it. Pharmacokinetics, what the body does to the drug. Distribution. Increased body fat and reduced total body water increase the volume of distribution of lipid-soluble drugs, prolonging their effect, while reducing the volume for water-soluble drugs, raising their initial concentration. Reduced plasma albumin increases the free fraction of highly protein-bound drugs. Metabolism, reduced hepatic mass and blood flow slow hepatic clearance. Excretion, reduced renal clearance prolongs the effect of renally eliminated drugs and their active metabolites, morphine being a key example, whose metabolite morphine 6-glucuronide accumulates. Pharmacodynamics, what the drug does to the body. There is increased end organ sensitivity, particularly of the brain, to anesthetic agents, opioids, and benzodiazepines, independent of the kinetic changes.
What are the practical prescribing principles?
The guiding maxim is start low and go slow. Reduce doses, induction agent requirements fall substantially. Propofol and thiopentone doses should be reduced by around 20 to 40% and given slowly, because a slow circulation time delays the onset and tempts overdosing. Titrate to effect rather than to a fixed milligram per kilogram dose. Allow longer for onset and offset. Avoid or minimize drugs with a poor profile in the elderly, particularly long-acting benzodiazepines, and drugs with anticholinergic activity, which are strongly associated with delirium. Anticipate prolonged effect of opioids and neuromuscular blockers, and monitor objectively, quantitative neuromuscular monitoring, and processed EEG to titrate depth.
Tell me more about anticholinergic burden.
Anticholinergic burden is the cumulative effect of all drugs with anticholinergic activity that a patient is taking, and it is strongly associated with cognitive impairment, delirium, falls, and mortality in the elderly. Many common drugs contribute. Some antihistamines, antidepressants, antipsychotics, bladder antimuscarinics, and antiemetics such as cyclizine and the anticholinergic promedicants. The clinical implication is to review and minimize the anticholinergic load perioperatively, to avoid adding to it with our own drug choices, and to prefer agents with low central anticholinergic activity. For example, glycopyrronium over atropine when an antimuscarinic is needed, as it does not cross the blood-brain barrier.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
How does preoperative assessment of the older patient differ from the standard assessment?
It is broader and more holistic, extending well beyond organ system disease. The recommended model is comprehensive geriatric assessment, a multidimensional, multidisciplinary process assessing medical, functional, cognitive, psychological, social, and environmental domains. Delivered in a perioperative service such as the POPS model, it has been shown to reduce complications, length of stay, and improve outcomes. In addition to the usual cardiorespiratory assessment and functional capacity and metabolic equivalence, I would specifically assess frailty using a validated scale, cognition with a baseline test such as the mini-cog or the 4AT, both to detect existing impairment and to provide a baseline for detecting postoperative delirium, nutrition, functional independence in activities of daily living, falls and mobility, a full medication review, and the patient's social circumstances and support.
What can be optimized before surgery?
Several modifiable factors, ideally addressed early in a prehabilitation framework. Anemia, identified and treated with iron, as anemia is common and associated with worse outcomes and transfusion. Comorbidities, blood pressure, glycemic control, heart failure and respiratory disease optimized. Medication review, stopping or reducing high-risk drugs, particularly those contributing to anticholinergic burden, falls and bleeding. Nutrition, correcting deficiency and considering supplementation. Physical and functional optimization, exercise-based prehabilitation where time allows. Cognitive and psychological preparation, and ensuring sensory aids, glasses and hearing aids are available, which reduces delirium. And crucially, honest shared decision-making about realistic goals and outcomes.
Say more about shared decision-making in this group.
Shared decision-making is central to ethical geriatric perioperative care. The conversation should establish what matters to the patient. For many older people, maintaining independence and cognitive function matters more than longevity. And a treatment that prolongs life at the cost of institutionalization may not be what they want. It should present realistic, individualized risk based on frailty and biological age. The alternatives, including non-operative and palliative options, and the likely trajectory of recovery. It must respect capacity, assessed for the specific decision, and where capacity is lacking, proceed through best interests processes with appropriate advocates. The presence of or need for an advanced care plan, treatment escalation plan, and resuscitation status should be addressed before surgery, not in the middle of a crisis.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
You have alluded to delirium. Define postoperative delirium and explain its importance.
Postoperative delirium is an acute, fluctuating disturbance of attention and awareness, with disorganized thinking or an altered level of consciousness, developing over hours to days after surgery. It is classified as hyperactive, hypoactive, or mixed, and the hypoactive form, characterized by withdrawal and reduced activity, is the most common and the most often missed, yet carries the worst prognosis. It is extremely important. It affects a large proportion of older surgical patients, up to half after major or emergency surgery and hip fracture, and is associated with increased mortality, longer stay, functional and cognitive decline, institutionalization, and persistent long-term cognitive impairment. It is also, in large part, preventable, which is why it is the focus of the A Brain Health Initiative and multiple international guidelines.
What are the risk factors?
They are divided into predisposing and precipitating factors. Predisposing, patient factors present before surgery. Advanced age, pre-existing cognitive impairment or dementia, frailty, depression, sensory impairment, poor functional status, polypharmacy and alcohol excess. Precipitating, perioperative insults. Pain, certain drugs, benzodiazepines, anticholinergics and possibly long-acting opioids, sepsis and infection, metabolic disturbance, hypoxia, dehydration, anemia, urinary retention and catheters, constipation, sleep disruption, an unfamiliar environment and immobility. Delirium typically results from a precipitant acting on a vulnerable, predisposed brain, so a small insult may trigger it in a frail patient, while a large one is needed in a fit one.
How do you prevent and manage it?
Prevention is far more effective than treatment, and is largely through multi-component non-pharmacological measures, as in the Hospital Elder Life program. Prevention, maintain orientation, ensure glasses and hearing aids are worn, promote a normal sleep-wake cycle and daytime mobilization, maintain hydration and nutrition, manage pain effectively with opioid-sparing multimodal analgesia, avoid precipitant drugs, treat infection, hypoxia and metabolic disturbance promptly, avoid unnecessary catheters and lines, and minimize environmental disruption. Interoperatively, avoiding excessively deep anesthesia, guided by processed EEG, and avoiding benzodiazepines and anticholinergics may reduce risk, and dexmedetomidine has some supportive evidence. Management of established delirium. Identify and treat the underlying cause, continue the non-pharmacological measures, and reserve pharmacological treatment, low-dose haloperidol or an atypical antipsychotic, only for severe agitation that threatens safety, at the lowest effective dose for the shortest time, as drugs do not treat the delirium itself and carry their own risks.
And postoperative cognitive dysfunction, how does it differ?
Postoperative cognitive dysfunction, now incorporated into the term perioperative neurocognitive disorders in the updated nomenclature, is a more subtle, longer-lasting decline in cognitive domains such as memory and executive function, detected on formal neuropsychological testing weeks to months after surgery, in a patient who is otherwise alert and not delirious. Unlike delirium, it is not an acute confusional state, and there is no fluctuating attention deficit. Its cause is debated and probably multifactorial: the surgical inflammatory response, the patient's underlying neurocognitive trajectory, and possibly anesthetic factors, and the evidence that any particular anesthetic technique prevents it is weak. The emphasis is on identifying at-risk patients, honest counseling, and the same brain protective principles used for delirium.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
What are the principles of intraoperative management in the older patient?
The overarching principle is to maintain physiological stability within a narrowed margin of reserve, while protecting the brain. Drugs start low, go slow, titrate to effect, with reduced doses and objective monitoring. Hemodynamics, avoid both hypotension and hypertension. The aging brain and heart are intolerant of swings, and intraoperative hypotension is associated with myocardial and renal injury, and possibly delirium. Maintain blood pressure close to the patient's own baseline. Monitoring processed EEG to avoid excessive depth. Quantitative neuromuscular monitoring to ensure full reversal. Invasive monitoring proportionate to the patient and surgery. And diligent temperature monitoring and active warming, as the elderly become hypothermic readily and hypothermia worsens coagulation, drug metabolism, wound healing, and cardiac outcome. Positioning and skin care meticulous, because of fragile skin, osteoporotic joints and pressure area vulnerability. Fluids judicious and goal-directed, avoiding both hypovolemia and overload in a heart and kidney with little reserve.
Is regional anesthesia preferable to general anesthesia in the elderly?
This is a long-standing and important question, and the honest answer is nuanced. Regional anesthesia offers theoretical advantages: avoidance of airway instrumentation, reduced systemic opioid and anesthetic exposure, excellent analgesia, reduced respiratory complications, reduced blood loss in some surgery, and a lower rate of venous thromboembolism. However, large randomized trials, particularly in hip fracture surgery, such as the RAGAR and REGAIN trials, have not demonstrated a clear reduction in mortality or in delirium with spinal compared with general anesthesia. So while regional is an excellent and often preferred technique, especially for its analgesic and respiratory benefits, I would not claim it is universally superior or that it prevents delirium. The technique should be chosen for the individual patient and procedure. What matters most is that whichever technique is used, it is conducted meticulously. Stable hemodynamics, appropriate depth, multimodal analgesia, and brain protective principles.
What if you use spinal anesthesia with sedation?
Then I would be cautious with the sedation, because deep or benzodiazepine-based sedation may negate the benefits of avoiding general anesthesia and may itself precipitate delirium. There is evidence, for example from a sub-study of hip fracture trials, that lighter sedation is associated with less delirium than deeper sedation in vulnerable patients. I would use the minimum sedation necessary, titrate carefully, monitor depth, avoid benzodiazepines where possible, and maintain verbal contact and reassurance.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
How do you approach analgesia in the older patient?
With a multimodal, opioid-sparing strategy, balancing the harms of undertreated pain, which itself causes delirium, immobility, and complications, against the harms of analgesic drugs in the elderly. Paracetamol is the backbone, regularly and at full dose unless contraindicated. Non-steroidal anti-inflammatories are used with great caution. Because of renal impairment, gastrointestinal bleeding, and cardiovascular risk, often avoided altogether in the frail elderly. Opioids are used at reduced doses, titrated, with anticipation of prolonged effect and accumulation of active metabolites. Morphine is used cautiously given renal accumulation, and agents such as oxycodone may be preferable in renal impairment. Regional and local techniques, peripheral nerve blocks, fascial plane blocks, wound infiltration, and neuraxial techniques are particularly valuable for their opioid-sparing effect. I would avoid or minimize adjuncts that worsen the anticholinergic burden or cause sedation, and assess pain with tools validated for those with cognitive impairment, such as observational pain scales, since self-report may be unreliable in delirium or dementia.
Outline your post-operative care priorities.
The priorities follow directly from the vulnerabilities we have discussed. An appropriate level of care, a higher dependency environment for the high-risk patient, with the recognition that specialist geriatric input, as in the POPS model, improves outcomes. Active delirium prevention, orientation, sensory aids, sleep, mobilization, hydration, and avoidance of precipitants. Effective multimodal analgesia and avoidance of oversedation. Early mobilization and early nutrition within an enhanced recovery framework. Vigilant monitoring for the complications to which the elderly are prone: cardiac, respiratory, renal, infective, and thromboembolic. Thromboprophylaxis, balancing venous thromboembolism risk against bleeding. Medication reconciliation and review, restarting and rationalizing chronic medications. And early discharge planning with the multidisciplinary team, focused on restoring function and independence, not merely surviving the operation.
How do you manage the patient who lacks capacity?
Through a structured, legally and ethically grounded process. Capacity is decision-specific and time-specific, and is assessed for the particular decision in question. Can the patient understand, retain, weigh, and communicate the relevant information? Capacity must not be assumed to be absent merely because of age, dementia, or an unwise decision. Where capacity is lacking, I would act in the patient's best interests, taking into account any advanced decision, lasting power of attorney or appointed deputy, and consulting those close to the patient and the wider team. I would seek the least restrictive option that achieves the goal, and document the assessment and the decision-making process. The framework varies by jurisdiction. The Mental Capacity Act in England and Wales, with equivalents elsewhere, but the principles of autonomy, best interests, and proportionality are common.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
What are the particular considerations for the older patient presenting for emergency surgery, such as a fractured hip?
Hip fracture is the archetypal high-risk geriatric emergency and is the subject of dedicated national pathways and audit. The principles: prompt surgery, generally within 36 to 48 hours because delay worsens outcome. Rapid optimization rather than prolonged investigation, correcting only what is genuinely correctable and not delaying for marginal gains. Early effective analgesia, ideally with a regional nerve block such as a fascia iliaca block, which reduces opioid requirement and delirium. And ortho-geriatric co-management, which has a strong evidence base for improving survival and function. The anesthetic, spinal or general, is chosen for the individual, conducted meticulously, with attention to hemodynamic stability and brain protection, and with light rather than deep sedation if a spinal is used.
And the older patient for major elective surgery, say, major colorectal or vascular surgery.
Here there is time to do things properly. I would pursue comprehensive geriatric assessment and prehabilitation, optimizing anemia, comorbidity, nutrition and fitness. Objective risk assessment, potentially including cardiopulmonary exercise testing, and detailed shared decision-making about the realistic risks and the trajectory of recovery, including the possibility of loss of independence. Interoperatively, the brain protective and stability principles apply, with goal-directed fluid therapy and active warming. Postoperatively, enhanced recovery within a geriatric co-managed pathway, planned higher-level care, delirium prevention, and early multidisciplinary discharge planning. The aim throughout is to return the patient not merely alive, but functional and independent.
Final question: 5 take-home messages on geriatric anesthesia.
1. Treat the biological age, not the chronological age. Frailty and functional status predict outcome far better than the number of years, and decisions must never be based on age alone. 2. Start low and go slow. The elderly need less drug and are more sensitive to it. Titrate to effect, anticipate prolonged action, and avoid benzodiazepines and anticholinergics. 3. Protect the brain. Postoperative delirium is common, dangerous, often missed in its hypoactive form, and largely preventable through multi-component non-pharmacological measures. 4. No anesthetic technique is magically superior. Meticulous conduct is what matters. Stable hemodynamics, appropriate depth, normothermia, multimodal opioid-sparing analgesia, and light sedation if a spinal is used. 5. Think beyond the operation. Comprehensive geriatric assessment, prehabilitation, honest shared decision-making, orthogeriatric or POPS co-management, and a focus on restoring independence are what transform outcomes for older surgical patients.
Thank you. That concludes this station.